Good afternoon all, Prynhawn da pawb. The event will now begin. Mae'r digwyddiad hwn ar fi'n dechrau.
Croeso, diolch yn dod y Prynhawn. I'm Claire Bevan and I'm the Registered Nurse and SRO for the Digitisation of Nursing Documentation Project in Wales. With me today is Mr Jonathan Pinkney, the Programme Manager for the Single Record, Digital Health and Care Wales, and Mr Matthew Knott, Head of Digital Applications, Swansea Bay University Health Board, and Chair of the Welsh Nursing Care Record Technical and Data Workstream. Also, Mr Wayne Kennedy, Principal Solutions Architect of Swansea Bay UHB. We'd like to welcome you to this Welsh Nursing Care Record Stakeholder Engagement event. The aim is to share the journey of the development of the Digital Welsh Nursing Care Record for our adult inpatients, focusing on the technical and data workstream, all informing the development of our single patient record. We'd like to thank you for taking the time to join us, and we value your thoughts and feedback to inform the next steps of the Welsh Nursing Care Record journey for our patients, staff, organisations and our key stakeholders. There will be an opportunity for Q&A during the session, so please share your name and time for questions at the end with the panel at the end of the presentation. And Mr Donald Kennedy, the Lead Infrastructure Design Architect from Digital Health and Care Wales, will also be joining us. We'll be designing the April Digital Nursing Newsletter based on the frequently asked questions and feedback from this series of engagement events. We'll now start the presentation with Jonathan.
Thanks, Claire. So just to let you know, my name is John Pinkney. I'm the Programme Manager for DHCW. I was the Principal Project Manager for the project, the Welsh Nursing Care Project. So just before I start, I've got a bit of a sore throat today, so if I go croaky, please excuse me. So the first question we like to ask, why nursing documentation? So a number of years ago, a series of reports and reviews were carried out, and the outcome of lots of those was identification of poor quality nursing documentation during the audits, namely the completeness and the timeliness of them. There was also a lack of document standardisation, not just between health boards, but often paper versions between wards would vary as well. Between wards in the same site, sorry. So, that leads to a situation where you have a little bit of inequality of care risk. Also, it requires manual auditing to assess the quality, which is time consuming and often takes the nurse away from patient care, which was never a good thing. Having the data locked away on paper, makes it inaccessible to many clinicians, so that low visibility of the patient record is a real problem. That also then leads to duplication of documents, so lots of repetitive questioning, the patient kind of getting asked the same questions in different parts of their stay as an inpatient. And it's, whilst frustrating for the nurse, it's also not great for the patient because they may not feel that they're being listened to. And it's not a good basis really for building trust in our relationship with them as a caregiver. So I think the next slide, this is a set of drawers on a ward, and it shows the problem from a slightly different perspective. So each one of these drawers has got a new nursing, a new assessment or care document that the nurse needs to fill in. And over the years, I think the nursing profession have been very accommodating. Something happens, an issue occurs, and then they end up in this challenging situation where they get another piece of paper, another document, another assessment to carry out. And I actually did count them. There's 130 drawers. So even just the concept of finding the assessment you need to carry out can be frustrating for nurses on paper. And then obviously the last bit, you probably bump your leg against it every time you walk up and down the ward. So what did we aim to do? So the aims of the project were, first off, standardised nursing documentation, and we wanted to improve the quality, the consistency, and also then the experience of nurses and patients. We wanted to reduce the burden of documentation on nurses, and through the reuse of data and integration of systems, save them some of that time that they were were using everything to repeat themselves, and also then give them more time back to care. You know, the reason they're a nurse is to be by the bedside and support patients. So we were really keen on that link, and you know, we developed a mobile solution to allow them to continue documenting at the bedside. Also to increase patient safety, aid in decision making, driving quality and timeliness of assessments. So a great example of this is a skin pressure ulcer assessment. You know, if a patient ends up with a pressure ulcer when they're in hospital because they've not been moved and they've not been provided with the appropriate care, that's a poor experience for the patient. And obviously it will mean they probably need more care, more time in hospital, care when they go out of hospital, and you may end up in a, you know, worst case scenario. Then, you know, they may end up litigating the health board as well. So it's not a great experience. And also then the last point was improving use of data for auditing and communication. So using the data to support clinical decision making, and lastly, you know, using the data to automate some of the reporting and free up some of that auditing time that the nurses were spending their time doing. So the next few slides will just talk us through the journey over the last 5 years, where we've come from, and we'll finish up with a position of where we are and what it means right now. Then I'll hand over to my other colleagues who are going to go into some of the more technical side of things. So we were really lucky in April 2017 to be awarded through efficiency through technology 1.19 million over 3 years to develop this platform as part of phase 1. During that year, we were set a really challenging date of getting something live by November 19, following a commitment of Public Accounts Committee. The first year, we focused really on initial engagement with nurses across Wales and lots of stakeholders. Claire, who introduced us, and our colleague Fran Beadle spoke to lots of nurses and identified the need for standardisation, and also looked at which forms would be needed in that first phase. They also picked up there was a need for nursing to become much more involved in the digital community, and they acted upon this and set about creating chief nursing information officers in each health board to really take the baton in terms of digital nursing. And we also then in early 2018 formed the project board, and I think at that point the kind of scale of the challenge for November 19 was emphasised. So moving on into 18-19, 2018 was all about standardisation of clinical tools. We worked with specialty groups from across Wales, specialty nurses, to give us recommendations of new evidence-based clinical tools that we would then take to digitise and implement within the system. In April of that year, we also formed the CNIO team. It really was the start of a journey for everybody. I think we often hear the phrase, men are from Mars and women from Venus. Well, that was the same picture, I guess, with nurses and digital colleagues in the early stages. And a good example, we were in a meeting talking about an MI, which to informatics colleagues is a major incident. So there's been some problem and all the computer systems have gone down, and all the nurses were kind of looking around a bit confused, because to them, of course, an MI is a myocardial infarction. So they were wondering who had a heart attack. So that's a really good illustration of the journey that we've been on. And that team have really, really come together as a collective digital nurse team now and really guide our work. That summer, we engaged with senior groups, not just the chief execs and medical nursing and therapies directors, but also finance and workforce, really about preparing the organisations and the staff for the change. We were well aware from the start, you know, the nursing community in Wales is the largest workforce in the country. We reviewed our technical options, and we took a decision in the autumn to utilise an existing NHS Wales in-house development. Swansea Bay had developed an in-house application themselves, and it was the ideal tool to kind of make use of existing NHS Wales resources and provide us a foundation to deliver against the challenging timescales. And as you can see, we didn't quite start the development then until January 19, which was applying the data standards and the new clinical tools against the system. So moving on into 1920. In the summer of this year, we identified a need for 2 bespoke functional technical items. And I think my colleague Wayne is going to cover these later, but essentially there was a need to have a solution for recovering digitally born data in the event of WNCR downtime. You know, nurses said, if the system drops out, we need to know patients' care information before we can touch them. And also then a solution for agency workers. So, you know, there is a huge demand on agency staff in the nursing area, and often those people come from, you know, England. They don't have NADEX IDs, and you don't know who they are until they even turn up 5 minutes before they start their shift. We did get our initial minimum viable product release live in the summer of that year, and out for testing in the summer of that year. The testing identified a kind of a number of bugs and tweaks which were required to the way that WNCR worked. Alone, none of them were significant, but kind of collectively, it meant that the product wasn't quite ready. We were really keen to win over the nursing community, and you know, we felt they deserved to have the application when it would provide them lots of benefit. So technical and clinical colleagues, we came together to make a recommendation that was accepted by board to have an additional round of development and testing, and that would really not put us on the back foot from the off with our early adopters. So we went ahead and did that and replanned for the early part of 2020. We got live across 7 health board sites, near enough simultaneously for between 2 and 4 weeks each. Obviously, as everybody is well aware, that is that time when the COVID pandemic started, and you know, the situation on hospital wards and the NHS in general became untenable really for us to implement. And while some health boards were looking to keep the systems on, we had to shut down, and obviously everybody started working on the pandemic response. So moving into 2020, into April 2020 and 2021 financial year, we started off by looking at the evaluation of the pilots. Obviously engagement was a little bit difficult, but we did get lots of feedback. There was lots of positivity, but also some key enhancements and new features identified that would really benefit nurses in the way that WNCR worked. And our plan was to build those into the first 2 live releases, version 2.0 and version 2.1. At the start of that year, we were really pleased that, considering all the stuff that was going on with COVID, we were able to get funding from Welsh Government via DPIF for an additional 2 years, 2.9 million, and that allowed us from October 2020 to bring in lots more local support to really help with boots on the ground in the implementation. We released the version 2.0 for testing in the autumn. Unfortunately, COVID again hit availability and impacted, you know, key staff who were needed to help with the project, and obviously the ward situation again was not ideal. So we replanned for the spring of 2021. The Nursing Times honoured us with an award in November of 2020, which was for the technology and data in nursing. And considering we weren't live yet, we were really pleased that our data standards work, and getting those standards across Wales had been truly recognised by that organisation. Really pleased to say that April 2021 we did go live finally in Hywel Dda, Swansea Bay and Velindre, which was quickly followed up by Powys, Teaching Health Board, and Cwmtaf in June and August. By this time, I think nurses were really keen to start using the application. I mean, after the previous year, I don't think anybody would have blamed them for not being able to kind of face the implementation of a brand new way of working and transitioning from paper to working on iPads. But I think in a style that really does epitomise the nursing profession, they rolled up their sleeves and they got on with it and got stuck in. And I have to give them huge credit for their attitude and application, and also then to the local and the national teams who are kind of dogged really in supporting readiness for the go lives, and also in supporting users through the go live. We got version 2.1, which is the kind of second tranche of evaluation feedback that went into that release. That went live in the autumn of last year across all live sites. We were incredibly humbled to win a second accolade, this time at the UK IT Industry Awards, and it was for the best healthcare sector IT project, which I think is testament to how much difference we were able to demonstrate that the application is making to the work of nurses and patient care, in a relatively short time period. And I think it reflects how the project's been a kind of truly clinically focused endeavour and a real collaboration between clinical and digital. More recently, we've been pleased to have a further round of funding awarded for 22-23 to continue the implementation. I'm happy to say that Betsy Cadwallader went live last week, and Cardiff and Vale are planned very soon, and an Iron Bevan also in the first half of the year. And we've also recently had a gateway review, which was identified some things for us to work on, but also some really good feedback for the project as well. So that brings us up to date. Where are we now, and kind of what does it all mean? Well, this is the map showing where we're live. We're now live in, I think it's 20 hospital sites and over 70 wards. And I think it's been a real rapid rollout, and we'll continue that way over the next year. And with everybody looking to scale up, Howell are actually only one hospital away, Glangwili, from completing the Rural Health Board, which has been made great progress. And what does it mean? Well, we've also produced this infographic to show you since go live in April 2021. We've had over 4,000 distinct users use the system. We've allocated over 8,000 temporary accounts, which Wayne will go into a little bit later. We're having on average over 3,000 monthly users. We've assessed nearly 18,000 inpatients digitally, and those 18,000 patients have amounted for nearly 500,000 digital risk assessments and over 800,000 inpatient nursing notes. The numbers have been huge, which have been great. Of the patients we've assessed, 16,000 have left hospital and their assessments have been closed and shared via our national repository, which has made them available across Wales via Welsh Clinical Portal. And 3/4 of those assessments have actually been viewed in WCP, and 16% of those views have been across health board boundaries. So it just shows the value of that data transitioning across health board boundaries. And lastly, just what are the benefits? So financially, Neath Port Talbot have carried out a detailed evaluation over 5 months for the 5 wards in their site, and they're approximating an annual saving on paper of around £18,000, which just in Neath Port Talbot Hospital equates to, I think it's 139 metres of paper. And if you extrapolate it out across the health board, I think it's over 2 kilometres, which is ginormous, really. Efficiency-wise, they identified a release of 257 hours time to care. That's just from the time in which they taken to complete assessments. 352 hours just on retrieving assessments and notes, and that's forecast for the whole year. Also, colleagues in Powys, a palliative care nurse, shared that it's saving her in some instances up to 2 hours in travel time for virtual entry, so she's not having to drive somewhere to write in paper notes, which is saving time, but also contributing towards decarbonisation efforts as well. And just from an effectiveness perspective, quality-wise, Neath Port Talbot have identified a 35% improvement in compliance rates for adult assessments, and 8 to 53% improvement in risk assessment completion rates. And I think the overall is somewhere in the region of a third. So when you couple together, they're doing a third more and they're doing that in less time. That's really powerful. We've also had lots of feedback from the nurses that they're really pleased with the application as well. So that's it for my section. I hope you found it useful. If you have any questions, please post them in the chat and we'll come back to you in the Q&A, and try and post your names. So if there's anything that we can't answer, we'll try and get back to you after the session. So I'd like to hand over to Wayne.
Thanks, John. Hi, everyone. As Claire said, I'm Wayne Kennedy. I'm the Principal Solution Architect for Swansea Bay University Health Board, and for the last 6 or so years I've also been the development lead for the WNCR project, initially in Swansea Bay, and then when we went to the national solution. What I'd like to do today is just give you a brief outline of the development history to date and some sort of key aspects, and then take you through 4 elements of the design and development of WNCR, which we found needed a bit more innovation during the process. Thanks, John. So the first one is just to say that the development team in Swansea Bay that developed WNCR is quite small. We've got 1 dev lead, myself, and 2 developers that work on the solution. And since 2019, as John said, when we went to the national solution, we've completed over 750 individual development tasks. That could mean bug fixing from SIT or UAT to the standard changes that John mentioned that were required for the national rollout. The application itself, for the geeks among us, is a web application using Bootstrap 5.1 for the UI. Entity framework linking to SQL 2016 database, and we use .NET 4.8 with a MVC pattern. Up to date, or as of yesterday actually when I run the query, we've actually audited over 14.5 million user actions in the application across the 6 health boards that are currently live with WNCR. So as John said, it's really being used quite a lot at the moment, and the rollout isn't complete yet, which is great. The application integrates with all the PAS systems used by health boards in Wales. The 6 health boards that use the Welsh PAS, that integration is 2-way, so we can read information and we can update information back into the PAS system. And for a couple of the health boards that have got their own PASs, then it's a read-only integration route. The application code is stored in our repository, which is Subversion. And we use Jenkins for continuous and on-demand deployment. WNCR itself is deployed to 10 servers across 2 data centers, one in Cardiff and I think one in Church. To deploy an application to SIT or UAT or live, we press a button which runs a Jenkins script. On average, that deployment will take us between 15 and 18 minutes to deploy to the 10 servers. The continuous deployment that is mentioned on the screen there relates to the fact that when a developer checks in any bit of code for WNCR, then Jenkins will immediately sort of grab that check-in and build and deploy a new version of the application to a development server. This allows us to test for bugs immediately on check-in to see if the build has been broken. So that was just a little bit of a summary on the WNCR development to date. What I'd like to do now is just go through 4 elements of the design in a bit more detail. So first of all, we'll be looking at the fact that early on we realised that WNCR would be needed to be completed at the patient's bedside. How we would deliver WNCR for temporary staff, as John mentioned. The model for delivering a technical business continuity solution for WNCR, which is highlighted very early on in the process as being critical. And then just a sort of a brief summary of how we transition from paper to the digital world. So first of all, nurses will need to speak to patients before filling in the application. That's quite obvious. They ask the patient a question and they'll sort of come back to the application and record the answer. So it was immediately obviously, unlike a lot of systems in the NHS where a nurse can go to a nurse station and complete it, this application would be needed to be completed and accessible at the patient's bedside. So therefore it would be used on the multiple devices ranging from desktops to laptops on carts to mobile devices and iPads like you can see on the screen. So we needed to make sure we had a responsive design. It was easy to read and find information on the system. Easy to navigate because the nursing teams could be navigating with their fingers on iPads or with keyboards or mice on a desktop. Controls easy to use, and the most important one is that the application, particularly for the AIA and all the assessments, would be familiar with a logical and intuitive flow to it, which would result in a minimal training effort. And basically what we were trying to do is mimic the paper as much as we could. So if you look at the next slide, I'll just give you a brief sort of outline. This is a screenshot from the actual application. This is the UAT version. And I'll just sort of highlight some elements for you. At the top is the system tray, which holds all the relevant system information for the user, where they logged into, what server they're on, any notifications that may be arising for them. And then on the left-hand side, there are two fixed elements. At the top left is the patient banner, which is always in the top left position. So the nursing teams, when they're on the patient, know exactly where to look for the patient information. And that's a patient safety critical point as well. And then underneath that is a menu for the various different sections for the assessment. In WNCR, I think there's 34 different sections. And depending on how the nurse goes through the assessment, the menu is highlighted to show them where they are. In the center panel, you can see the actual, just go back a second. Yeah, on the center panel, you can just see the communication care domain section. And you'll notice that we laid it out in a single column with the labels at the top aligned. And this was in line with some UX design, which states that a single column with top aligned headers is easier for the user to process and actually results in a quicker completion rate of the form. So that's why you'll see that most of the sections are like that. Some are not, but most of the sections where the user or the nurse is asking the patient a question will be in aligned that manner. You'll also notice there's quite a lot of white space. You might think that's quite a lot of white space on the screen. That's there intentionally. That screenshot is from my monitor, which is bigger than NASA's, so it's quite a large. But if that was screen was shown on an iPad, then that white space would disappear, but the layout of the form would be the same. So when the nursing teams move from a desktop to a laptop to an iPad, they see a familiar UI going through it. You'll also see we don't use much color. It's mainly black and white. And we only use color really for either statuses or navigation purposes. And you can see at the bottom there, you can see the save and next button. It's clear and plain for the nursing team to know that when they click that, they'll move on to the next section. And if we move on to the next section, you'll see that on the next slide, a nurse user has actually started to complete the communication care domain and has started to answer some of the questions. So they've asked the patient, do you have a sight problem, for example, and the patient's replied yes. And you'll see that unlike the first screen, the previous screen, a child section has now opened up on the screen. And again, this was intentional. We were making sure that the nursing teams only see what is necessary because it's easier for them to process the information. The nursing teams are hugely busy. They're doing like 100 things at once. It's incredible when you see them working. So the application was trying to be as intuitive and easy for them to use as possible. And if they answer a question and that results in something else needed to be asked, then we'll show it. If it doesn't, we don't show it to start with. And that was a real sort of saving for the nursing teams because they haven't got to read questions that they haven't got to complete. So that was just sort of an overview of the WNCR at the bedside. One of the things John mentioned was that a lot of staff in Wales, and probably across the country actually, are not full-time staff of a health board. They're agency staff or students. And this became particularly true during COVID, where a lot more agency staff were needed on wards. And I heard anecdotal evidence of some wards being staffed with nearly 80% agency staff at any time. And that agency staff could, turn up on very short notice. So we had to find a solution to allow a agency member of staff to access the WNCR application. So we came up with the temporary staff solution. And basically, and we'll show you on the next slide in a second, but basically it allows a health board nurse user to register a temporary staff worker on WNCR. They've only got to fill in a very minimal amount of information about that temporary staff user, name and address, name and PIN number, sorry, shift start and end dates. And the application then automatically assigns a Cymru or NADIX or Active Directory, call it what you will, account that allows that temporary staff member to log into the application. And the application as well, behind the scenes, also deals with removing or deactivating that temporary staff member from the application, and that does it automatically an hour after the shift end date. So if we move to the next slide, you'll see that's the temporary worker registration form that's presented to a ward team leader, for example, on a ward when they're working on WNCR. So if that team leader had an agency member of staff start with them, they would log into the application, navigate to this page, and click the button called Next Free. What that does is then it would go off to our Active Directory various OUs across Wales, and each health board has got their own, and each health board has already pre-registered a group of temporary accounts. So these accounts are not assigned to individuals yet, they're just pre-registered. So by clicking that Next Free, we will go off and get the next free directory account for that health board, and that would allow then the team leader on the ward to fill in the rest of the information for the temporary staff member, ideally including the registration PIN if they're a nurse, but obviously if they're not a nurse, they may not have a PIN, but if they are a nurse, they can register that as well. And then they would ask the temporary staff member to enter their own password and confirm it, and on clicking the registration button at the bottom, that would then register that account to the new staff member for the duration of the shift. And then the temporary staff member then can log into WNCR and carry out the actions like anybody else for that shift period. And the audit behind the scenes will audit the fact that the temporary account was assigned to that individual member of staff for that period. Yet after the shift ends, that temporary account can be reused by another staff member at another time. And I think the feedback we've had, that's been used many times, and as I said, because of the COVID, more so than we thought, but it's been really successful. Moving on to the technical business continuity. Early on in the project, the clinical teams highlighted the fact that because we're moving from paper to digital, they won't have any paper. So they will obviously need some sort of way of looking at the digital document. If the worst case scenario happened and WNCR was down, or even the network was down. So we had to come up with something that would produce almost continuous and real-time updates to the business continuity model. It was secure and yet still auditable. And the process we've done ticks all those, and we'll take you through exactly how it works in a second. So if you go to the next slide, there's 4 key elements to business continuity. The first thing is WNCR itself. Whenever a user logs into WNCR and makes a change to the patient's assessment, that information is saved into a database, and we have a background service which is run by our hangfire assembly, which will look at that job, pick it up and process it, and produce a HTML file of the containing the last 7 days of information for that patient's assessment. That background service will then put that HTML file on the BC share, you can see there, which is still on the WNCR servers. The next element of the BC model is the integration. You'll notice there's a little sort of square rhombus, there, which says robocopy. And we use robocopy scripts to transfer the HTML BC files from our servers, or in DHCW, to the health board shares across Wales. And that runs every 5 minutes. So it's as up to date and as live as possible. Then you look at the left-hand side, you can see the health board client. So this is, you can imagine now, this is the actual wards in the various health boards across Wales. In every ward, there's one health board, there's one machine device designated a BC device. That could be a desktop that's got encryption on it, or it could be a laptop. That device is on all the time and is continually pulling, again with robocopy, looking for files from the health board share and pulling them down to that individual device. When it does pull it down, it pulls it down to a folder structure that's secure with a service account that only the health board client and the BC viewer knows. And the last element is the BC viewer. And John, if you can just click the next button to run. The BC viewer is a very small, it's a simple web application, Windows application that we developed that is installed on the client device in the health board on each ward, and it allows teams in times of BC to log into the BC viewer, search for a patient, find the patient's assessment, view it as a PDF on the screen, or if they need to print it out to a linked printer that could be linked to the individual device. You can see this Robocopies, you can see on the screen at the moment, is continuous. It keeps each of the elements in sync. So if a patient has been discharged from the hospital and has gone home, then we would take that assessment out of the BC viewer, so it doesn't need to be viewed any longer. If we move to the next screen, it just gives you a quick summary of the BC viewer itself. Very simple Windows application. Top sort of screen there shows you the simple login. And again, you put the your NADEX or Cymru or username in. Temporary users can still use this as well, just to let you know. So if you are a temporary member of staff and you've just been registered as a temporary worker, you can still log into the BC viewer. That's part of the process. It's secure. It won't let you in unless you have access to WNCR itself. There's a security feature in the back end that checks that, even if it's offline. You can see the user there search for a patient number and then has selected that patient and is shown the PDF of the assessment, which outlines the last 7 days for that patient. We were originally doing it for all the patients, so the full patient assessment, but they're so big that the nursing teams have decided to cut it down to the last 7 days because that's enough information to use in a BC environment. So that's just a brief summary of the BC. And the final thing I want to talk about is really the transition from paper to digital. And really, I feel a bit of a fraud here because it's not really me you've done this, it's the clinical teams, the nursing teams, they're the champions on this really, because they've got together across Wales and done something miraculous, I think, which is agreed a standard. And that's, that's really quite hard to do, but that's what they've done. So those teams and our business teams have got together, looked at the standards of paper documents now and agreed to change to come to one sort of standard paper document. And once we've got that, then we could look at it and we use that as the sort of starting point, the translation to digital. And we went through a series of continuous improvement rotations where we spoke to the users, showed them designs, acted upon the feedback, showed them new designs, acted upon the feedback. So it's a real sort of transformation for myself, and as a developer, it's been a real eye opener on this working on this application, a real joy really to work with the nursing teams across Wales. You realise how much benefit it's having and how much impact it's going to have on patients being admitted to the hospital. So that's really just a brief summary. I'll pass you over to Matt now, who will give you the sort of future of WNCR.
Thanks, Wayne. And good afternoon, everyone. So I'm Matthew Knott. I'm the head of digital applications in Swansea Bay, and I'm also the chair of the tech and data group for WNCR. Thanks, John. Next slide. So first of all, just a quick description about how we're looking to align with open architecture. So Welsh Government commissioned a review of the national architecture, which was published back in 2019. One of the outcomes of the report was a clear need to move towards a more open architecture. What does that mean then? So for us, moving towards open architecture means faster, easier access to data and a clear and transparent design and systems communicating in a common language. And we're seeing clear progress on this from within DHDW after the report, with work on key elements like the API management gateway, clinical data engine, and the fire facade process progressing well. WNCR were already was well in development when the report was released in 2019, and one of the things we didn't want to do was to preempt the findings of the report. So WNCR as a project really focused on one of its core values, which is delivering maximum benefit to nurses as quickly as possible. We did, however, commit to evolving the WNCR technical roadmap in line with the recommendations of the review, specifically around how the open architecture. So we're going to look at some of the ways WNCR will aim to align with the principles of open architecture now. So next slide, please, John. Thanks. So first of all, fire profiling. Fire is essentially a set of building blocks that defines APIs, documents, and structured messages, and how they can work between systems. And fire profiling specifically describes the process of aligning the data within a system to corresponding fire profiles so that these messages can be easily and safely shared between systems. This work will be critical to the efficiency on the digital ward, so we're already seeing numerous opportunities to share data between WNCR and other clinical systems where functionality can sometimes overlap. Therefore, our ambition must be to push interoperability so that nurses don't have to duplicate effort. There's still some way to go in defining the fire profiles that are needed for WNCR. However, NHS Wales is fully engaged with other nations on the development of Fire UK Core, which will in time give us the tools to deliver true interoperability within WNCR. Next slide, please, John. So talking about open data for a moment then. So from a data perspective, the goal is to have a single, secure, reliable source of structured data which conforms to agreed standards. This will allow anyone with authorization to make use of that data with minimal effort. The infrastructure would effectively get out of the way, allowing effort to be focused on what matters in the health domain, whilst providing valuable insights. WNCR data will power new and emerging areas such as machine learning, whilst also encouraging third-party development. So for nurses, this would make applications easier to use and more data will be collected automatically rather than it needed to be keyed in, and dashboards will have rich and timely data. Through automation and data-driven decision-making, nurses will be able to concentrate on patient care, with the IT acting as a welcome assistant, giving confidence in timely decision-making. Next slide, please, John. So a brief bit about dashboards. Work has recently completed to give the health boards access to the underlying nursing data from WNCR, and this is a vital step in understanding the criticality of some of the data the system holds. Whilst we've empowered health boards to do their own insights into the data, we also recognise the value of being able to show performance information directly to nurses within WNCR. So we have some example dashboards just showing what is possible and clearly showing at a patient level any outstanding or overdue tasks, or summarising this data at a ward level. As John mentioned at the start, WNCR has led to a higher rate of document completion, and these dashboards can only help to drive that rate even higher. Next slide, please, John. So next, I just want to talk about cloud briefly. WNCR is currently hosted in a couple of DHDW data centres, as Wayne mentioned. However, the vision long term is to move the software into the cloud. Moving WNCR to the cloud is something we see as not only important in aligning to the DHDW cloud strategy, but also as an opportunity to improve upon WNCR and make it more fit for the future and scalable to meet growing demand. Next slide, please, John. So for those of you who design or maintain software, you'll be very familiar with this simplified diagram of the WNCR core architecture. We have a user accessing a browser-based application that reads and writes data from a database. As Wayne obviously went into a lot of the technicalities around WNCR, And as you can appreciate, there's integration, caches, load balancers, and a highly automated deployment process that's not represented in this diagram. But at the heart, it's a monolithic design, which isn't a bad thing at all. But keeping this design and a move to the cloud would probably be a missed opportunity. Next slide, please. So to try and put it in simple terms, managing the performance of monolith can be really challenging, and when confronted with performance issues, you're often restricted to quite two-dimensional changes of additional compute resource or servers. This can be really inefficient. It's like turning the volume of a song up to 10 just to hear something quiet in the background a bit more clearly. So what we want is a model that allows much more fine-tuning of performance so that we're giving resources to the hardest working components. Next slide, please. So one possible design and a way we could take advantage of the cloud would be to transition WNCR to a microservices design. This is much more than splitting WNCR into components and hosting them separately. It's about looking at creating a system of components that can function independently. So in this model, if we lost any one element, the rest of the software could continue to function largely completely and correctly with fully synchronized data sets that there's minimal impact. On top of this planned resilience, we also have the benefit of elasticity and the ability to automatically scale the resources of a module vertically and horizontally according to demand. Next slide, please, John. So finally, from me, is just some reflections on the technical journey so far and just what some of the learnings are. Next slide, please, John. So first of all is around the alignment with the open architecture and the way in which WNCR has progressed in this space already. WNCR has moved at pace and it has been nicknamed the WNCR Express, which is something we're really proud of. This is mostly thanks to commitment across the entire team to, as I said previously, put maximum value into the user's hands as quickly as possible. This has been an important, but it is sometimes a divisive decision across NHS Wales, and I think it's hard to reflect on the technical progression of the system without acknowledging this. The first principle of agile software development, which was established almost 30 years ago, is our highest priority is to satisfy the customer through early and continuous delivery of valuable software. And I feel the team have done that, committing to adopting the standards and processes as and when they become available. It's also important to note the alignment with and development of technical standards would not be possible without the huge effort that's gone into developing the clinical standards up front as part of the WNCR process. Next slide, please, John. So the second reflection is around the need for greater pace and visibility of change. And when I talk about that, it's the perception of change. So we're now deep in the development of single instance of WNCR, which is an extremely technical release and is completely focused on bringing all of the separate instances of WNCR back into a single application. So this means a sustained period where nothing visibly changes for the users. And whilst this is a necessary technical change and the right time to do it, it's also a difficult period for nurses who really love WNCR and are desperate for new functionality and further digitalization. When we've delivered single instance, we come to start version 2.3. We're listening to user feedback about the need to see change on a more regular basis. But to do that, we're going to need to be more agile across the whole process, and that's from requirements gathering through to implementation if we're going to deliver incrementally and more often. This isn't just about changing how software development happens. So this is a major challenge given the difficulty of signing off and testing, scheduling downtime, but it is something that we will be striving for in future releases. Thanks, John. Next slide. So the last reflection then is to think about how we can improve user-centered design. Something that might actually help with a more rapid release schedule is thinking about how we prototype forms and functionality and collaborate. Wireframes are a quick and easy way of presenting form layouts and content to stakeholder groups, but we frequently see changes coming forward late in the development process or in UAT, and we need to consider why. So one aspect we'll look at is whether we can use more advanced tools that are available often for free as well, like Figma or Envision, to better collaborate with our stakeholders, trying to create a richer simulation of how a form will look and function when it's developed. So our hope is that by changing our approach, we can develop a better understanding of the proposals and reduce the number of changes later in the design process. So that's it for me, and we now welcome any questions.
That's brilliant. Thank you, Matt. If there are any final questions, I can see we've got some in the published in the live Q&A already. Please pop any more questions that you've got in, and we'll try and get through them in the next 10 minutes. So just have a little look. I'd like to welcome as well Donald. Thank you for joining us. So the first question, is there a plan to link WNCR to community nursing documentation and nursing teams, and if so, when? So we have worked really closely actually in the early phase when we've talked about standards. We've worked really closely with our colleagues in the community areas to ensure that we were aligned to the way they are doing things and that our standards marry up. So that has resulted in clinical care domains being the kind of structure that we've taken in the nursing application, and what it means by having the data the same, whilst they're not interoperating at the moment, it does mean that we've got apples and apples and pears and pears. So when some of the open architecture stuff that Matt has alluded to kind of comes to fruition, that is where that will come to be a real strength, and we will be able to then transition data, whether they're down to a very clinical data item or then looking at documents going out and being shared with community teams. We also publish our data to that Welsh Care Record Service, which I mentioned, and I think it's also in the pipeline for the community care information system to connect up to be able to view those documents as well. So that would also give those community teams the ability to tap into the nursing data, from a document level. So there's another question from Elizabeth about the slides being available. So we won't be making them publicly available, Elizabeth, but we will be posting the whole session onto our DHCW YouTube. So this session is being recorded and will be available for reconsumption at a later date. If you've got any specifics, I'd kind of suggest speaking to your local clinical nurse informatics officer, and they are on our website, a list of those, and they would be able to help you with any specific request for information. So there's another question. Why are there often many listings of the same patient? I sometimes need to search for information about discharge patients, and it's not possible to see which has the clinical record, even when searching with NHS number. Wayne, I don't know if you might be able to pick this one up. I'm not sure if this is referencing possibly multiple or duplicate IDs, maybe in the PAS applications.
Yes, I mean, obviously, unfortunately, in most PASs actually, but certainly in the Welsh PAS system, NHS number is not unique. So more than one record in the PAS system can have the same NHS number. So that's the first thing to remember. The uniqueness in the PAS system is actually the hospital number or the CRN number, you might hear it called. So that's the first thing. We have got a solution in Wales called MPI, which is Master Patient Index, where we try to link all duplicate patients. Duplicate patient records, from the PASs into one sort of master record. So the WNCR itself isn't linked to that yet. It's actually in the next phase. So therefore, just imagine patient number 1 had hospital number 1 in Swansea Bay, hospital number 2 in Cwmtaf, hospital number 3 in Velindre, for example. Then in MPI, those numbers should be linked ideally, or they will be linked if the information is close enough. And when you search for that NHS number from say Cwmtaf, it will also bring you back the records from Velindre and Swansea Bay as well. And then we can bring that information back down to WNCR, and we could find out if that patient's got assessments from other health boards and other hospitals underneath other numbers. So I'm not sure if that answers your question or not. In terms of the patient in PAS being there more than once, it can happen, unfortunately. Working with the health board now for 16, 17 years, unfortunately, there are duplicate registrations. They do happen. Patient will get registered today from a clinic, and then 6 months later will unfortunately arrive in the ED department knocked out, and a new registration will take place for that patient. And then when the patient comes around, they realise it's the same patient that was there before. What happens then is usually in the PAS system, an amalgamation takes place. When that amalgamation takes place in the PAS system, a message gets sent out. It's actually a HL7 A40 message. Will get sent out from the PAS system down to WNCR, and we will do the amalgamation on the WNCR database for that patient's records as well. So I'm not sure if that's answered the question. If you want to come back, that's fine. That's great.
Well, thank you, Wayne. Okay, so we've got another question about catheter. Can the question be catheter be changed? While searching, I found that a nurse had ticked not normally catheterized. However, the patient had been catheterized on admission, so they weren't strictly incorrect as the patient wasn't normally catheterized prior to admission. Can the catheter question create an alert on discharge to remind staff to ensure that the patient has a catheter passport upon discharge? So Claire, you're the clinical expert on this call. I would guess that would be the case, and we could do that via an RFC, but I don't know if you want to add anything to that.
Yeah, so obviously patient's care will change on admission and during their admission in hospital. If they have a urinary catheter inserted, that would be documented in the Welsh Nursing Care record. But just to provide assurance, in the discharge checklist tool that has been created in the Welsh Nursing Care record, there is a question about, does the patient have a catheter? And obviously that's then to ensure that they add into the passport the date of the removal of the catheter. And there's a question about if the patient needs a referral. So the nurse can also add in the referral details of the district nurse in the checklist as well. So I hope that answers the question. John, you're on mute.
Apologies, classic mistake. Okay, there's a further question about timescale for the release of raw data to the health boards. Matt, I don't know if you are able to pick this up. I know we've achieved this already, but obviously as we kind of iterate.
Yeah, sorry. So what's the question?
So do we have a timescale for the release of the raw data to the health boards?
Yeah, so we are making good progress on that, aren't we? And that we've John, you might be better to comment on this, but in terms of how we've enabled through the National Data Warehouse the access to the WNCR data, you know, it's our ambition ultimately to integrate with the NDR as and when we've got a mechanism for doing so, and to really transform that. We don't have a timescale for those elements yet.
Okay, well, thanks, Matt. And yeah, just to add, I guess we've only recently made that available in the last couple of weeks, so we're going to be working with clinical and information colleagues to work up some of the stuff that Matt did illustrate in his slide around, you know, dashboards, etc. So I hope that's helpful. And obviously, information colleagues will be then working on the reporting, etc. A timeframe for linking WNCR to mental health and learning disabilities in Hywel Dda. So we are working, Liz, with our colleagues in the community space and obviously the community care information system. So we're currently focused on adult inpatient wards. We are looking at how WNCR is going to be rolled out to other areas. But I think we'll probably be more linking in the data to making sure that's available to colleagues in those teams who need access to the data. A further question, can there be entries by CNSs that don't get buried in the data, for example, add in a specific care plan or advice? So I think this question might be aimed at the nursing, the inpatient notes function. So we are looking at how that works across other note-taking functions within our plethora of products, including Welsh Clinical Portal. And there is actually the ability within WNCR to filter those to find the specific notes that you've entered, whether that's by a note type, i.e. a specialty like occupational therapy or physio, or by individual as well, or by date and time. We're working on care plans as a further deliverable of the application. There's a question from Jackie Barnes. Do you have product manager, service owner roles for ongoing development, and how do you manage the product pipeline? So we're currently working towards our transition to business as usual within over the next year, planning for April 2023, and we are planning to have ongoing development of the application at that time as we move away from project funding and project structure. As I said, my role is in the area of the single record team within DHCW, and we are one of the first areas to migrate over to a kind of product focused approach. So we're starting that transition, and those are some of the things that we're looking at. But ultimately, we work very closely with Wayne and Matt and our BAs and clinical. So I think we're very product focused already. We don't have product manager roles per se, but that is something that is being considered in the future. And I think that's it. I do think we've got a video to show before we finish. Thank you, Daisy. And we hope you found the feedback useful, the session useful.
Hi, my name is Christine Evans. I'm Ward Manager on the Neuro Rehabilitation Unit in East Portobello Hospital. It's become such a fantastic way forward for nursing, in that it's clear, concise documentation. There's no room for error. It highlights all the risk assessments that we need. It's easily accessible for everybody, all the MDT, physios, occupational therapists, speech and language. Anybody can access the WNCR at any time. It's become a real valuable piece of equipment for the nursing staff.
It's changed how I work because everything is in one place. You never lose a bit of paper and you don't have to run around the wards looking for something.
I think it's better to capture all the information with the patients as well, so you can go through everything in one go. So it definitely saves time, and I think it's better for patient care because it means we can spend more time with them than completing paperwork.
It's a lot easier. All the information's at a touch of a button, all the risk assessments are there, and we can read everybody's writing.
The system's been quite easy to use. We were given a lot of support and reassurance from the IT department when we first got up and running, and the access to it is quite easy to navigate once you get used to it.
Using the computer to input patient notes would be very beneficial. On a personal level, I'm dyslexic and I find it very difficult with my spelling, so it takes me a lot longer to write my notes. But using the computer format has eliminated that problem, so it's levelling out the playing field a bit, really, and actually enabling me to speed up my notes because I'm not having to Google how to spell everything. So it's much easier, and it also makes it easier to understand other people's notes because everyone's got different ways with their handwriting, so it just makes everything clearer.
Hi, I'm Trudy Young. I'm the tissue viability nurse here at Velindre. For me, the important thing is about the pressure ulcer risk assessment we use at Velindre, which is a Purpose T tool. The Purpose T tool is part of the risk assessment suite on the WNCR, and what I like about it is that staff, when they're completing it, cannot submitted unless it's completed in full. So where in the past when we used the paper versions we had errors and omissions, this doesn't happen with the Purpose T, and that's absolutely superb. Also for me, for audit purposes, I can look back at the scores, look at the equipment being used, and it helps me to give a picture of what's happening to the patients on the ward in relation to their pressure ulcer risk assessments. It's a great benefit to me.
Hi, my name is Jane Brady and I'm the Senior Lead Nursing Informatics Specialist for Betsy Cadwallader University Health Board. For me, we're at a very exciting time in BCU currently because we are planning to go live hopefully the first week of March with the Welsh Nursing Care Record, and that will be in one of our community hospitals. We've started that engagement and had conversations and trying to get plans in place, and the feedback that we're getting currently is that everybody's really excited about it and feel that it's been such a long time coming that they can't wait to get going.
I'd like to thank you all very much for attending this session this afternoon. I think that video says it all. It demonstrates how our clinical colleagues and our technical colleagues have worked in collaboration, listening to each other to do the best that we can with the design of the Welsh Nursing Care Record for our patients. We will be collating all the FAQs from today's session in the April digital newsletter. So please do look out for that, and we'd just like to thank you again for your time, and please keep contributing as we want to make this the best we can for Wales. Thank you.